Welcome everyone. In this video we shall be talking about cell death and discuss all the MCQs related to it. So moving on to the first question, which are the following recognized forms or which are the following are recognized forms of programmed cell death? Remember the fact that the only form of cell death which is not a programmed cell death is necrosis. Necrosis is not a programmed cell death. Remaining almost everything is a programmed cell death. Apoptosis, yes, it's a programmed cell death which is caspase dependent. Autophagy is also a programmed cell death which is nothing but cellular, self-digestion. Pyroptosis is also a programmed cell death where interleukin 1 and inflammasomes play a role. And necroptosis is also a programmed cell death which is rather a programmed necrosis. Okay. Over here answer would be D. Moving on to the next question. Necrosis is characterized by, remember that necrosis is nothing but a pathological cell death. Remember that necrosis is characterized by cellular swelling, it is characterized by mitochondrial swelling, it is characterized by rupture of the membrane, it is considered characterized by rupture of the cell membrane that leads to release of the contents into the extracellular space, release of the contents from the intracellular space into the extracellular space, right? And is also associated with inflammation because of the release of the products, right? And remember that it is ATP independent, rather there is depletion of ATP in necrosis, right? Even in absent ATP, necrosis can occur. So let's have a look into the options. ATP dependent DNA fragmentation, that's a false statement. DNA fragmentation might be found in necrosis, but it is not ATP dependent. Okay, it is not, I'm so sorry, it is not ATP dependent. ATP dependent DNA fragmentation is found in apoptosis, right? Swelling of mitochondrial cell lysis, yes, that's a characteristic feature of necrosis where we get cell lysis and release of contents. Phagocytosis of apoptotic bodies will be seen in apoptosis, not in necrosis. Absence of inflammation, that's again a false statement. Inflammation will be present in necrosis. Okay. Moving on to the next question. Which of the following shows liquefactive necrosis? Remember that liquefactive necrosis is due to enzymatic digestion, and is seen in brain, is seen in abscess, is seen in wet gangrene, and is also seen in fungal infection. The most common thing that we need to remember is brain. Right? Now if we have a look into the images, right, this is a brain, and what do we see over here? That the outline of the damage is not maintained. Properly. The outline is not preserved. So liquefactive necrosis, the characteristic feature of liquefactive necrosis is that the outline of the tissue damage is also not maintained, whereas in coagulative necrosis we would find that the outline is maintained, right? So over here A should be our answer. A is our liquefactive necrosis, right, seen in a brain. Okay. If we have a look into the other images, this is an image of a lung, right, and we see over here the cheesy material, the cheese-like appearance, right? So this is nothing but a caseous necrosis. Right? And we get caseous necrosis in TB, in histoplasma, another fungal infection like coccidioidomycosis. Right. If we look into this image, right, we get this chalky deposits. We get this chalky white deposits. Right. This is characteristic of fat necrosis. What happens in fat necrosis? The fatty acids chelate the calcium to cause this white deposits. Right. And that's why they will be seen in fatty acid rich areas, which are breast as in breast trauma, and in pancreatitis right. And these deposits might be seen in omentum or mesentery secondary to pancreatitis. Okay. Moving on to the final picture over here, you can see that this is a spleen. We can see it's a splenic infarct. It's a splenic infarct, and we can see very well that the outline is maintained. So this is an example of coagulative necrosis. We get preserved outline. So this is our coagulative necrosis. Okay. Coagulative necrosis can be seen in dry gangrene. And in burns. Okay. We are done with most of the types. Right. Moving on to the next question. Identify the type of necrosis as shown in the histopathological image. Now this is a blood vessel. Right. We can see the RBCs. Over here. And we can see surrounding the blood vessel is an eosinophilic. I'm so sorry. We see an eosinophilic fibrin-like. We get a fibrin-like material deposition. Surrounding the blood vessel. So this suggests of fibrinoid necrosis. Right. Remember that fibrinoid necrosis is seen in rheumatic heart disease. Right. In the Aschoff nodules. Right. We also see it in vasculitis. Right. Common example is polyarteritis nodosa, and also in malignant hypertension. Okay. If we look into the other options, in caseous necrosis in HP, we would get granulomatous. We get a granulomatous picture, right? In liquefactive and coagulative necrosis, we would get increase in eosinophilia, but not such fibrin-like deposits. Over here, there would be increase in eosinophilia. Right? In coagulative necrosis specifically, we would get a moth-eaten. Appearance. Right. And there would be increased glassy appearance. This glassy appearance is actually due to loss of glycogen, decreased loss of glycogen. And this eosinophilia is due to the loss of cytoplasmic RNA. Right. So this picture suggests us of fibrinoid necrosis. Okay. Moving on to the next question. A 56-year-old man with myocardial infarction shows preserved tissue architecture for 24 hours. And we get hypereosinophilic cells and loss of nuclei. What is the type of necrosis being described over here? It is myocardial infarction, which means it is involving your heart, which is a solid organ. The second important point that is written over here is preserved tissue architecture. Preserved tissue architecture is actually the hallmark of coagulative necrosis. Okay. So the answer would be coagulative necrosis. In liquefactive necrosis, we do not get no preservation of architecture, no preservation of tissues, no preservation of the architecture of the tissues. In fibrinoid necrosis, we would get fibrin deposits. But nothing has been mentioned over here. And in fat necrosis is actually seen in fatty acid rich areas like breast and pancreas, right? Okay, so our answer over here would be coagulative necrosis. Moving on to the next question. Arrange the following nuclear changes of necrosis in proper sequence. Now, we get three changes in necrosis, three nuclear changes in necrosis. Number one is pycnosis. What happens in pycnosis? There is nucleus shrinkage. Plus increase in basophilia. Right? Due to nucleus shrinkage, there will be increase in basophilia. Then comes the phase of karyorrhexis. Karyorrhexis, where there is fragmentation of the shrink nuclei, where there is a fragmentation of the pycnotic nuclei. Right. Nucleus, my bad. Right. Fragmentation of the pycnotic nucleus. Right. And finally, we get the karyolysis phase. Where there is dissolution of the fragments, dissolution of the fragments leading to decrease in basophilia, right? And the sequence is like this: pycnosis, karyorrhexis, karyolysis. So our answer would be A. Okay. Moving on to the next question. Match the following with examples. Aschoff nodules, you have read that Aschoff nodules is an example of fibrinoid necrosis. Pancreatitis is an example of fat necrosis. Burns, you have read that is an example of coagulative necrosis. Okay. Now over here the confusion starts. Fungal infection, histoplasmosis. Histoplasmosis is nothing but a fungal infection, right? So, but histoplasmosis is actually classically associated with lung granulomas. That's why we would associate it with caseous necrosis, and fungal infection with liquefactive necrosis. Okay. So our answer would be 1E, 2D. There is only one option with 1E. There is only one option with 1E. 1E, 2D, 3A, 4B, 5C. That is our correct answer. We need to remember the examples of various types of necrosis. Okay. Moving on to the next question. Which of the following are characteristics of apoptosis? Right. What are the characteristics of apoptosis? In apoptosis, we get cell shrinkage. We do not get cell swelling as in necrosis. We get cell shrinkage. The cell membrane is intact. There is no rupture. I'm so sorry. The cell membrane is intact. Right. There would be nuclear condensation. Right. That is pycnosis. Pycnosis will be present, and even fragmentation of the nucleus. Will be condensed nucleus will be present, and these fragmentation would be regular. This fragmentation is done by DNase enzyme, and it breaks the fragments into breaks the nucleus into regular fragments, equal sized fragments, right, in apoptosis. And the second, and then what happens? The cell membrane blebs out. Then the cell membrane blebs out into what? Into apoptotic bodies, and these apoptotic bodies now will be engulfed by the macrophages. And remember, since there is no release of contents from the cell, inflammation will be absent over here because the contents have not been released from the cell. So now let's have a look into the options. Cellular shrinkage, yes, that's a true statement. Nuclear condensation and fragmentation, yes, that's also a true statement. Plasma membrane rupture, no, that's a false statement. This is a characteristic of necrosis where we get rupture of the plasma membrane. And phagocytosis by macrophages without inflammation, that's a true statement. So our answer would be A, B and D. So C should be our answer. Okay. Moving on to the next question. Now the intrinsic or the mitochondrial pathway of apoptosis is initiated by. Now remember that apoptosis can take place via two ways. One is the intrinsic or the mitochondrial pathway. This is the most common pathway, right? And the second is the extrinsic or the death domain pathway. Now over here we are talking about the intrinsic pathway. Let's have a look into the intrinsic pathway. Now in intrinsic pathway, whenever there is cellular stress, the stress sensors are going to activate the pro-apoptotic factors. We will be talking about the stress sensors as well as pro-apoptotic factors a bit later. Now when they activate the pro-apoptotic factors, they are going to form channels. In the mitochondrial membrane. Now these channels are going to allow cytochrome C. Now the cytochrome C is a component of our electron transport chain and is present only inside mitochondria, right? Now when these channels are formed, this cytochrome C can be released into the cytoplasm. This allows the leakage of cytochrome C into the cytoplasm, and this cytochrome C combines with APAF1, that is apoptotic factor 1, and from over here this combination forms apoptosome. Now this apoptosome is something which can activate our caspase enzymes, activate caspase 9. Now this caspase 9 over here is the initiator caspase of the intrinsic pathway. It is the initiator caspase of the intrinsic pathway. This caspase 9 is going to now activate. This caspase 9 activates caspase 3, 6 and 7, which are the executioner caspase. And this finally leads to apoptosis. So this is the intrinsic pathway. Okay. Now let's have a look into the options. The intrinsic pathway of apoptosis is initiated by death receptor binding, no. Mitochondrial leakage of cytochrome C, that's a true statement. Activation of caspase 8, no, it would be caspase 9. Fast ligand binding to Fas, no, that's again a false statement. That is a part of extrinsic pathway. The answer would be B. Okay. Moving on to the next question. Which of the following is true regarding the extrinsic apoptotic pathway? Now let's have a look into the extrinsic pathway. What happens in the extrinsic pathway? The extrinsic pathway can be activated by two ways. Number one is the Fas binding to Fas ligand. Fas ligand binding to the Fas. And second way is TNF alpha binding to your TNF receptor. Now any one of them can lead to formation of death domain. Which is Fas associated death domain most commonly. Okay. Now this death domain is going to activate the procaspases. What are the procaspases? Over here it activates caspase 8 more than 10. Right. Now this 8 and 10 are the initiator caspase of the extrinsic pathway. Now this 8 and 10 activate caspase 3, 6 and 7 again, which are nothing but our execution caspases, right? And finally would lead to apoptosis. Okay. Now let's have a look into the option. Mediated by BCL2. No, BCL2 is actually an anti-apoptotic factor. It is an anti-apoptotic factor. We shall be learning about these factors soon, right? Triggered by Fas and Fas ligand or TNF receptor binding, that's a true statement. Involves caspase 9 activation, no, it involves caspase 8 more than caspase 10. And independent of caspases, no, that's a false statement. Our answer would be B. Okay. Moving on to the next question. Which of the following are anti-apoptotic factors? Now let's have a look into the factors, right? There are three types of factors in apoptosis: pro-apoptotic, anti-apoptotic and the stress sensors. Let's have a look into the pro-apoptotic factors. The pro-apoptotic factors are BAX and BAC, right? If we talk about the anti-apoptotic factors, which are BCL2, BCL-XL and MCL, right? Whenever you get this CL, this is anti-apoptotic. Okay. And finally we have the stress sensors, which are BIM, BID, BAD, PUMA and NOXA. These are stress sensors, right? They are the ones which are going to activate your pro-apoptotic factors. Okay. So have a look into the options. Anti-apoptotic, BCL2 yes, BCL-XL no, BCL-XL also yes, it's also an anti-apoptotic factor. BAX is a pro-apoptotic and BAD is also not an answer because BAD is a stress sensor. So answer would be A and B. Okay. Moving on to the next question. Which of the following are inhibitors of the process shown in the image? We can very well appreciate these are our apoptotic bodies. Just as a side note, remember there are two named apoptotic bodies. Number one is Councilman bodies. These Councilman bodies are actually seen in viral hepatitis. And the second one is the Cevade bodies. Which are seen in lichen planus. Right? Just remember the names. Okay. Now the process over here is nothing but our apoptosis, right? Which of the following are inhibitors? Now let's have a look into the options. IAP stands for inhibitor of apoptotic protein. What it does, it inhibits the intrinsic pathway. Okay. So here remember that we are talking about the inhibitors. Yes, so IAP would be an answer. SMAC and Diablo are actually inhibitors. SMAC and Diablo inhibits IAP. So technically they are pro-apoptotic. Okay. And flip is an inhibitor of the extrinsic pathway. So this is also a true option. Answer would be A and D. Okay. Moving on to the next question. A patient treated with anti-cancer drug develops apoptosis in tumor cells. Which of the following mediates this effect? Remember that anti-cancer drugs usually trigger the intrinsic pathway, usually triggers the intrinsic pathway. Okay. So what would be our answer? Caspase 3 activation. Yes, this is nothing but an executioner caspase. Cytochrome C leakage. Yes. ATP depletion. No, ATP depletion is not a characteristic of apoptosis. It is rather a characteristic of necrosis. And mitochondrial swelling. Mitochondrial swelling, again no. Mitochondrial swelling is also seen in necrosis, not in apoptosis. Rather mitochondrial shrinkage would be seen. ठीक. So our answer would be A and B. ठीक है. Moving on to the next question. Which of the following are examples of apoptosis? Examples of apoptosis. Embryogenesis. Yes, we do see apoptosis in embryogenesis. Councilman bodies. We just discussed councilman bodies and civet bodies are examples of apoptotic bodies. Endometrial shedding during menstruation. That's a true statement. Where we get hormonal withdrawal. And death of self-reactive lymphocytes. Over here also we see apoptosis. Now this plays an important role in development of central tolerance in our thymus. Now besides that, remember that so all four of them are answers. So answer would be D. Now besides these, remember that, right, any DNA damage beyond repair will trigger apoptosis. And other diseases like cystic fibrosis, like alpha-1 antitrypsin deficiency, right? Wherever we get diseases with misfolded proteins, are triggers of apoptosis. Okay. Misfolded, any disease due to misfolded disease, right, will trigger apoptosis. Okay. Moving on to the next question, right? Autophagy. Autophagy refers to, what does autophagy refers to? In autophagy, what happens? There is formation of autophagosomes. Autophagosomes are derived from ER. Autophagosomes are derived from our endoplasmic reticulum. What do? They engulf the organelles. They engulf cell organelles. Then they fuse with the lysosomes. And then there is digestion. And this digestion results in release of energy, which is utilized by the cell for its survival. Okay. So self-digestion of cell organelles by lysosome for survival. Yes, this is our answer. Phagocytosis by macrophages. No, phagocytosis by macrophages, there is external engulfment. Right? Apoptosis following mitochondrial leakage. No, apoptosis following mitochondrial leakage is apoptosis, of course. Right? Why would there be autophagy? Accidental cell death is necrosis. Right? This is not autophagy. Okay. Moving on to the next question. Which of the following are true regarding autophagy? LC3 acts as a marker for autophagy. That's a true statement. LC3 is a marker of autophagy, and besides LC3, ATG16 is also a marker for autophagy. Involves formation of autophagosome. Yes, this autophagosome is derived from endoplasmic reticulum. We just discussed that. Can be protective or lead to death. Yes, that's a true statement. Remember that autophagy begins as a survival mechanism. But when it is pushed to its limit, right? When it causes damage beyond repair, it will lead to cell death. Okay. And is caspase dependent? No, that's a false statement, right? There are two processes. One is necroptosis and second is autophagy. These two processes are caspase independent. Okay, necroptosis and autophagy are caspase independent processes. So our answer would be A, B and C. Okay. Moving on to the next question. Pyroptosis differs from apoptosis because of. Now pyroptosis is actually triggered by microbial toxins. It is triggered by microbial toxins. What do this? Microbial toxins are actually recognized by our nod-like receptors. Okay. And these nod-like receptors leads to activation of the inflammasomes. Now these inflammasomes leads to activation of caspase 1. Right over here the initiator is caspase 1, and this leads to increased interleukin 1. This leads to production of interleukin 1, and this interleukin 1 triggers fever as well as inflammation. Okay. Let's have a look into the option. It is caspase 3 dependent. That's a false statement. Caspase 3 is an executioner caspase for apoptosis. Over here caspase 1, 4, 5 and 11 are involved. in pyroptosis. Okay. It causes cellular swelling and inflammation. That's a true statement. Of course, there would be cellular swelling and inflammation. Remember, the cellular swelling is actually caused by something called the gas dermin pores. The gas dermin pores are characteristic findings seen in pyroptosis. There will be cellular pores that would result in cellular swelling and also release of the contents, triggering an inflammatory response. Okay. Mediated by caspase 1 and interleukin 1b. That's a 1 beta. Okay. Okay. And yes, it's 1 beta, and it occurs without DNA fragmentation. That's a false statement. Right? There is DNA fragmentation. Remember that DNA fragmentation is present, but a chief difference between pyroptosis and apoptosis is, in apoptosis we get regular fragments. Over here we would get irregular fragments. Okay. So answer would be B and C. Option B. Okay. Moving on to the next question. Necroptosis is characterized by necroptosis. Now, what happens in necroptosis is that TNF binds to our TNF receptor, and this leads to activation of RIP kinase 1 and 3. Right, RIP kinase 1 and 3. This is the initiator of the process. This RIP kinase 1 and 3 leads to phosphorylation. Of MLKL. What is MLKL? It is mixed lineage kinase domain-like proteins. MLKL proteins, which is mixed lineage kinase domain-like proteins. This activation would lead to plasma membrane damage. This leads to plasma membrane damage, right? Plus free radical injury. This free radical injury, plasma membrane damage, will trigger inflammation. Okay. Will trigger inflammation. Now let's have a look. Caspase 8 activation. No. Remember the fact that necroptosis is caspase independent. Okay. RIP kinase 1 and 3 are for activation. Yes. Pathway activation. That's a true statement. Morphologically similar to apoptosis. That's a false statement. It is morphologically similar to necrosis. It is sometimes also known as programmed necrosis. That's why we call it necroptosis. Right. It is similar to necrosis, where we get plasma membrane damage, where we get inflammation. Requires ATP? No, it again does not require ATP, right? Does not require ATP because it resembles necrosis, right? And one chief example that we need to, very characteristic example of necroptosis that we need to remember is nothing but development of mammalian growth plate. This is the only physiological example that we need to remember. Moving on to the next question. Lipid peroxidation and cell death. Due to excess iron accumulation is seen in ferroptosis, as the name suggests, excess iron. So it would be ferroptosis. What happens? Due to this excess iron, there would be increased free radical formation. Right? Now this free radical will cause lipid peroxidation. Of cell membrane. Lipid peroxidation of the cell membrane, that will lead to damage to membrane, right, and will trigger inflammatory response. Another important fact that it is associated with glutathione peroxidase inactivation. Right, it is associated with glutathione peroxidase inactivation. Okay. This is all about ferroptosis that we need to know. Moving on to the next question. Right, now FAS, a CD95 mutation, leads to defective apoptosis and accumulation of autoreactive lymphocytes. This is seen, and this is a characteristic feature of autoimmune lymphoproliferative syndrome. What happens in autoimmune lymphoproliferative syndrome? There is defective apoptosis. And accumulation of autoreactive lymphocytes. Right, now these autoreactive lymphocytes trigger autoimmune response. This will lead to autoimmune cytopenia. Right, it is also associated with chronic lymphadenopathy and splenomegaly. And another very characteristic feature of autoimmune lymphoproliferative syndrome is double negative T cells. What are double negative T cells? Which is CD4 as well as CD8 negative T cells. Okay. If you have a look into the other options in Sjogren's syndrome, we get autoimmune gland involvement. Right, like salivary gland involvement. Right, in Hashimoto we get autoimmune thyroid involvement. And DiGeorge syndrome, we get T cell defect. We get T cell defect due to thymic hypoplasia. Due to thymic hypoplasia, right? Right. We have discussed about DiGeorge syndrome in our video on immunodeficiency disorder. You can always refer to that video, right, for details. Let's move on to the next question. Right. Which of the following are lab markers for apoptosis? When DNA laddering on gel electrophoresis, what happens? The DNase enzyme is gonna cleave the DNA into 180 base pair fragments into regular fragments, right? Regular 180 base pair fragments that would lead to a step ladder formation, that would lead to a ladder pattern on agarose gel electrophoresis. Okay, so this is a true statement. Tunnel assay positivity, yes, this tunnel assay actually detects the fragmented DNA ends. The fragmented DNA ends, right? This fragmented DNA ends are detected in tunnel assay positivity, so this will also be positive in our apoptosis. Annexin 5 binding, yes, this annexin 5 actually binds to phosphatidyl serine. Binds to phosphatidyl serine. Normally phosphatidyl serine is actually present in the inner leaflet of the cell membrane, but when apoptosis is triggered, there is flipping of the membrane, and this phosphatidyl serine goes to the outer leaflet, right? And now they can be detected by the annexin 5 binding. That's why it is a marker of apoptosis, because in apoptosis phosphatidyl serine moves to the outer leaflet. Okay, on the outer leaflet of cell membrane. Okay. Release of, so this is also a true statement. Release of LDH, no. Release of LDH, in order to get release of LDH, the cell membrane needs to get disrupted. The cell membrane needs to get disrupted, right? But that is a feature of necrosis. So our answer over here would be A, B, and C. Okay. Moving on to the next question. Over here we get an agarose gel electrophoresis. What is the interpretation? Over here we see regularly spaced. We get regularly spaced bands. Right? That is equal sized fragments are seen. Which is characteristic of apoptosis, right? And this pattern is known as the step ladder pattern, right? Now, if you have a look into the option, random DNA fragmentation and necrosis, no. In necrosis, we would get a smear pattern on electrophoresis. DNA ladder apoptosis, this is our correct answer. Mitochondrial DNA release and autophagy, no. That's a false statement. Pyroptotic DNA fragment, over here we do not get regular fragments. We get irregular fragments, right? We get irregular fragments. Okay. Moving on to the next question. Identify the mechanism of cell death in the center of the image shown in the center. So this is a granulomatous picture. This is a granuloma, mostly a TB granuloma. Most common cause of a granuloma in India is TB. So in granuloma we get a central eosinophilic area which represents our caseous necrosis, and is surrounded by inflammatory cells. We get peripheral inflammatory cells. So our answer would be caseous necrosis. And TB is a very prime example. Right besides it, we can also it can also be seen in histoplasmosis. Okay. So with this, we come to the end of our discussion on cell death. If you like this video, consider subscribing to my channel, and thank you for watching.